Hello and welcome to Breast Grand Rounds. My name is Fiona Heggie and I'm a radiation oncologist within the breast cancer service at Peter Mac, and it's a great pleasure to welcome you here today. I'd like to begin by speaking in an acknowledgement of country. I would like to acknowledge the traditional custodians of the lands on which myself and today's presenter and audience are located. And I would also like to pay respects to elders, both past and present, and extend that respect to other Indigenous Australians present online. Thank you very much. And we'll just move on so I can tell you a little bit about how to ask questions. If you have questions during the presentation, you'll find at the bottom of the screen two ways of asking questions. You can click on the Q&A box on your Zoom screen or on the chat box. Please submit your questions throughout the presentation and then we'll try and answer them all at the end of the session. Please also note that today's webinar is being recorded and so you'll be able to view it on the BCCC Open Learning page. It's a great pleasure to introduce Professor Bruce Mann. I'm sure he's very well known to everybody in the audience. He's a specialist breast surgeon who holds positions at the Royal Women's, the Royal Melbourne and Peter MacCallum Cancer Centre, and has also got university appointments at the University of Melbourne and the Walter and Eliza Hall Institute. Bruce is really been an integral part of the breast cancer service, involved in integrating the breast units of the Royal Melbourne and the Royal Women's together, and also bringing them together subsequently with Peter MacCallum. And he's director of the breast cancer service across all three units. He's also chair of the board of the Breast Cancer Trials Australia and a board member of the Breast Cancer Network of Australia. And it's a great pleasure to hear him speak today on DCISionRT. So I will just open the floor to Bruce.
Thanks, Fiona, and thanks for the opportunity to present this work. This is the culmination of at least a decade's work. And for a long time, I didn't think it was going to come to anything. So I'm very pleased to show you what we have found. This is about DCISionRT, which is a biological risk signature. And let's hope this works. Okay, some IT issues. There is a conflict of interest. Funding for the study I'll be describing was provided by the Prelude Corporation that is the creator of the DCISionRT assay, and Troy Bremer, who's one of the authors, is founder and chief scientific officer. As background, we need to think about DCIS. That's ductal carcinoma in situ, well known to all of us who deal with breast screen and breast surgery. But what it is, it's a pre-malignant condition of the breast, and it's a non-obligate precursor. It is a proliferation, it's an abnormal proliferation of the cells that line the duct. These are the cells that give rise to most breast cancers. It's a pre-malignant condition because while the cells themselves look cancerous and have features of breast cancer, they remain confined to the duct because the basement membrane and the myoepithelial layer is intact. And while those cells are within the duct, they can't spread into the breast and therefore can't spread around the body. So it isn't a cancer, but it can become cancer. This was a rare condition prior to population screening. Some 3% of all breast malignancies or breast tumours were DCIS. But with population screening, it becomes dramatically more common, up to 25% or more of screen-detected cases. The outcome of treatment are excellent. However, recurrences are common after wide excision alone, after it's just excised, which means more extensive treatment is often recommended, possibly a mastectomy or possibly radiation. We can see this is figures from the United States, and the graphs are from the start of the century. You can see that the incidence of it, that's the top left graph, has increased dramatically. That's the red line, and that corresponded with screening. Most of it has been treated with breast conservation. You can see the rate of mastectomy is going went down as people became more comfortable treating DCIS with breast conservation, and the use of radiation went up. The reason the use of radiation went up relates to a number of randomized trials. This is a summary from the Early Breast Cancer Trials Collaborative Group of all of the randomized trials. And what the graph shows is the incidence of ipsilateral recurrence, so further DCIS or invasive recurrence in the same breast, either with breast-conserving surgery alone, that's the top line, 28% after 10 years, or breast-conserving surgery with radiation, some 13% at 10 years. So quite a dramatic reduction in the incidence of these events with the use of adjuvant radiation. A Cochrane review was done some years ago, headed by Nick Wilkin and colleagues from Sydney, where they reviewed the use of all the studies of post-operative radiation for DCIS. And their conclusion was that the review confirms the benefit of adding radiotherapy to breast-conserving surgery for all women diagnosed with DCIS. So it sounds fairly clear that we know what to do and we should just keep doing it. However, it is very controversial. Controversial to the extent that here was a Time magazine cover some 6 years ago, where concerns about DCIS led to a number of proposals. A proposal that it shouldn't be called cancer, that the C, the carcinoma in the word, should be removed because it's not actually cancer. Perhaps we shouldn't be biopsying the calcifications as much. Maybe that's leading to unnecessary diagnosis and treatment. And maybe even that this is a condition that shouldn't be treated. And a number of trials of active surveillance or watchful waiting have been implemented. So why is there the controversy? It seemed that it was fairly clear cut. And the issue relates to overdiagnosis and overtreatment. Overdiagnosis is the condition or the problem where conditions are identified that if they had not been found would never have become clinically apparent. Now, that is actually quite common across medicine, but DCIS is an example where we know that a number of the cases, if they are left alone, if they've never been found, would sit there either not progressing or only slowly progressing for the duration of that person's life. And if that is the case, not finding it is no harm. And along with overdiagnosis, there is overtreatment. So overdiagnosed cases, if they are treated, that treatment was unnecessary. Unfortunately, we cannot yet identify which case. And also the extent of treatment. Sometimes much of the treatment given may be unnecessary. So I think the problem, that's one level, but another way of looking at the problem that was highlighted in that Time magazine is that it scares our patients. It is sometimes called cancer, a shorthand perhaps, but a pre-malignant condition is called cancer. And often the way we treat DCIS, we are treating it as if it's cancer. And patients who've had DCIS, do many of them have a fear of cancer recurrence as if they've had a cancer. And then I think there's also some semantic issues of the words that we use. So sometimes if someone has had DCIS and then later on there is a further diagnosis, this is sometimes referred to as a treatment failure, when actually it's just another episode of a precancerous condition. And then we use the word recurrence. Recurrence implies a cancer's come back, but this is a pre-malignant condition, so it can hardly be a recurrence if cancer has never occurred. And while these might be minor points, it does lead to the overall concern that the harms of diagnosing and treating this condition may outweigh the benefits. Radiotherapy is an important aspect of breast cancer treatment. It's an important part of treatment of DCIS. As we've So apologies for that. So what is the problem? So radiotherapy is a very useful cancer treatment. I've got things popping up on my screen. Sorry, just got to close that. However, DCIS, my assessment is that with DCIS, the risks of DCIS are somewhat underappreciated and perhaps the benefits are overestimated. Here we go. A review from a paper out of JCO in 2017 provided an estimate of the risks of breast cancer radiotherapy with modern radiation doses. And here's the summary. It suggested that the absolute risk of radiation-associated mortality for smokers is 4%, 4% due to lung cancer, 1% from cardiac, and for non-smokers, a lung cancer and a cardiac mortality, both about 0.3%. The conclusion from the authors was that for smokers, the risk of modern radiation may outweigh the benefits, but for most non-smokers, the benefits far outweigh the risks. But my question would be, for DCIS, how does this fit in? In addition to those serious complications, there is the issue of persistent pain. And anyone who looks after the breast cancer patients or DCIS patients long-term is aware that persistent pain is a substantial problem. Here was a review from a Canadian medical journal. The associations with pain on a meta-analysis were young age, radiotherapy, and axillary node dissection. So we do need to be aware of it. We did some work, so that's the background to radiation. The Sloan Project is an important prospective cohort study from the UK of close to 13,000 patients who had screen detected DCIS. And what they looked at were variations in diagnostic, therapeutic, and outcomes. What they found in this was that 62% of those diagnosed with DCIS received radiotherapy. Strikingly and frighteningly, the variation in the use of radiotherapy across screening sites varied from something like 5% all the way up to 95%. Now, it's clear that that variation is not a patient or a pathology variation. That must be a provider variation that in different MDMs will assess the situation, leading to these dramatically different outcomes. Further outcomes from the Sloan study, there were a substantial number of events. There were some deaths, but breast cancer deaths were rare, 0.5% in this total cohort. And the breast cancer deaths were vastly outnumbered by other cause mortality. Radiotherapy after breast-conserving surgery was associated with reduced mortality, but only all-cause mortality, not breast cancer mortality, that can be seen here. And what we can see is that as far as breast cancer-specific mortality, there is no difference. All-cause mortality was different, presumably because the older and less well patients who were more likely to die from something else were less likely to receive radiation. So when we, as clinicians, are faced with the management of caring for someone with DCIS, the key issues are that we need to assess the local recurrence risk, particularly the risk of invasive recurrence. We should aim to identify cases possibly for observation, but that isn't really done yet. And what we need for that is we have some unmet needs with tools to help tailor the treatment for individual patients, ideally with some prognostic markers, a marker that can identify the risk of recurrence with or without treatment, and thereby predictive markers for the benefit from radiation. A number of, or two key studies from North America have been done to try to inform the use of radiation. These are both important studies. One's the E5194 study, which was a single-arm prospective study where patients had local excision with a minimum margin of 3 millimeters. They were divided into 2 cohorts. One of them was the lower intermediate grade, less than 2.5 centimeters. Cohort 2 was high grade, less than 1 centimeter, small cancers. And here are the results of it. The top left is all events, bottom left is invasive events, and panel C on the right is DCIS events. The most important of these is clearly the invasive events. And what you can see in this single-arm study out to 12 years, despite it being an apparently low-risk group with clear surgical margins, in cohort 2, which is the high-grade lesions, the incidence of an ipsilateral invasive cancer was over 10%. And for the lower grade tumours, it was just under 10%. This is really the state of the art for, based on standard pathological grounds, low-risk groups. RTOG 9804 is the other key study. This was a randomized trial of wide excision with or without radiation for what was assessed as good risk DCIS. And good risk here is similar to the cohort A in the ECOG study, screen detected, lower intermediate grade, less than 2.5 centimeters with a wide margin. And what was found here, again, the rate of local recurrence, that's the top left, it was low in both arms, but clearly much lower in those who received radiation. But the lower panels show that the survival was no different. Moving on to biomarkers, in invasive cancer for decades, we would not look after a patient with invasive cancer without knowing more about the cancer. The receptor status and the HER2 status is absolutely routine. Ki67 is another marker. It's a marker of proliferation. There are reliability issues, but many do find it useful. In distinction for DCIS, markers are not routinely measured, and up until recently were rarely measured. And in none of those studies have the biomarkers been incorporated, and therefore they're not used in guidelines. Now, this is because they haven't been used and they haven't been tested, rather than because it's been proven they are of no benefit. In the literature, there aren't many studies to guide us. There are some smallish studies that have been published. This was one that shows that a high grade and high Ki67 is associated with an increased risk of recurrence. Here's another from JAMA Oncology some time ago, showing that mortality of those with ER negative DCIS is somewhat higher than those with ER positive. But keep in mind, if you look at the y-axis, this is from 90% to 100%. So this is, the numbers are very small. And that's the type of data we've got. Microarrays are useful in the management of some invasive cancer. Tests such as Oncotype or PAM50, EndoPredict, MammaPrint, they have all been developed. They are clearly prognostic and appear to have some chemopredictive ability. And some work was done by Genomic Health to modify their Oncotype DX to see whether it could be useful in the management of DCIS. And what they did is they looked at the ECOG series and looked at their markers and identified some markers that appeared to be prognostic in this already low-risk group. So they did a validation study to see whether their Oncotype DCIS score was associated with the local recurrence risk. And what they found is that there was some association, and they came up with a test which is available. It can be purchased, And this shows, according to the DCIS score, there is some predicting, there is a prognostic value for both any local recurrence and invasive local recurrence. So this is of some value, but while it has been further validated in another cohort from Ontario, it may be useful, but it's not widely used. The main concerns are that the differential is not very great. There is no predictive aspect of it. This is not demonstrating a benefit from radiation. And there's also concern that the eligibility in the study was narrow. This was only in low-risk groups. And this is where the biological risk signature, known as DCISionRT, may come into it. Background to our involvement is that we had published a series of cases from Royal Melbourne in the early days of screening where DCIS, where radiation was used fairly sparingly. And we published that our local recurrence rate at 8 years was about 18%. In patients who had received, only about 15% of the patients had received radiation. That was in line with other publications. I'm not sure why that happened. And I was contacted by the people from Prelude to see whether we may be interested in validating the assay that they were developing. They have developed this assay known as DCISionRT. It was based on basic science, mainly done at UCSF. It was then developed and validated in series from Uppsala University, Sweden, and the University of Massachusetts. And what the assay is, it's comprised of 7 immunohistochemical markers and 4 clinical markers that are combined in a non-linear manner to come up with a single decision score. Now, the non-linear combination is key, and it's very complicated, but looking at the 2 markers, P16 and Ki67, gives some insight into it. P16, the scientists in the room will know far more than me, but it's a regulator of the RB gene. And when it was examined in DCIS, those that were low and high in P16, there was no difference in their local recurrence rate. Ki67, I've mentioned before, is a proliferation marker. And when this is measured, there is some difference. Those with DCIS with a high Ki67, as I showed in a previous slide, has a somewhat higher rate of local recurrence. When the P16 low cases are looked at, Ki67 actually has no prognostic significance. So P16 low, Ki67 low or high, no difference. However, when P16 high is measured, then there's a dramatic difference in the rate of local recurrence between the Ki67 low and high. And this is the non-linear algorithm that has been developed that goes into the DCISionRT. So the prior studies, there have been two previous validations, one of them from Kaiser Permanente and one of them from the Swedish DCIS randomized trial. These were both presented at San Antonio in previous years. And here's the summary. This is what we've got here is the ipsilateral either invasive or total event rate. And in those that have a high decision score, down on the x-axis, we've got the decision score going from 0 to 10. Those that have a high decision score, there is a dramatic reduction in the rate of local recurrence. But those with a low decision score, there's very little difference. And that leads to the Royal Melbourne validation study. We identified 183 women with DCIS in a contemporary cohort from 2006 to 2011. all treated at hospitals associated with Northwest Breast Screen with breast-conserving surgery with or without radiation. The primary objective of the study was to see whether the decision score was prognostic for recurrence risk, and the secondary objective to see whether it was predictive of radiation benefit. Here is an analysis of the cohort. You can see this is those treated without and with radiation. The median age, as expected from a screening cohort, was 59. Median extent was 3.4 centimetres, and importantly, 83% would not have met the RTOG low risk criteria. Median, I'll just go back, median follow-up was a little over 6 years. 39% received radiation as per the general policies of the unit. And of those with high grade, grade 3 DCIS, 50% received RT, and about a third were prescribed endocrine therapy. When this 183 were reclassified, so slides and necessary clinical data was shipped to the Prelude lab, they reclassified, or they classified all of them with their decision RT. 54% of the total population were found to be low risk. And interestingly, the distribution of low and high risk according to grade and size, there wasn't much in it. Those that were grade 3 were slightly more likely to be high risk, but not greatly. Those that were larger, again, slightly more likely to be high risk. And here are the results. First, we looked at its prognostic ability. So this is looking at, on this side, it is all treatments. Those treated with breast-conserving, well, this is before using the assay. Those treated with breast-conserving surgery, 14% risk of incidence of local events. Breast-conserving surgery plus RT, 4%, the expected substantial reduction with the use of radiation. When we then looked at those treated without RT, so looking at the pure prognostic effect or benefit or value in the assay, those that had a low decision score without RT had a 7% incidence of ipsilateral events, as opposed to 23% of those that had the elevated decision score, an absolute difference of 16% that was highly significant. The next aspect is it, so that's the prognostic aspect. Probably more importantly is the predictive aspect. Is the decision score able to predict those patients who are likely to benefit or unlikely to benefit from radiation? So it did this first by excluding those with endocrine therapy. And you can see that so patients treated with or without radiation, but no endocrine therapy, who had a low decision score, this is on the right. The difference in ipsilateral event was only 2%, and that wasn't significant. Whereas those with an elevated score, the difference in event rate was 27%, highly significant, suggesting that in this group, the high elevated decision score implies a sensitivity to radiation, and actually the reverse. Those with a low decision score, no benefit from radiation. We did the same, including those with endocrine therapy, essentially found the same results. The difference was a little less, a little lower. So these are our results. Important, these are only 5-year results, and a very valid comment is that you need 10-year results to be able to make firm conclusions. The other series that have been published have been 10-year results, and the results are very similar, showing radiation leads to a substantial reduction in events overall. But those with a low decision score, the reduction with radiation is much smaller than those with a high decision score. When we go back to, there's an interesting thing here. When you go back to the overview showing this difference in ipsilateral event, There is a figure in that paper that doesn't get much attention, but this is the difference in event rate according to nuclear grade. And it is surprising, and you go check, because most people are surprised / don't believe this, that the impact of radiation, so the difference in event rate with at low, intermediate and high nuclear grade is the same. From the way we practice, you would assume that those with high nuclear grade have a higher event rate and a larger benefit from radiation. And while there might be a few % difference, there isn't great difference. And this follows on with, here's a composite slide that was provided to me by the people at Prelude, showing that in their cases, down the left column, there are 4 low nuclear grade, then 4 intermediate and 4 high nuclear grade. And the variation in the decision score in low grade from 1.1 up to 6.8, and in high grade from 0.8 all the way up to 10. So this throws into real question the way that we all generally use grade as a predictor. Now, I accept there are lots of data to say that those with high grade a higher rate of progression. However, it is not as clear cut as we might think. So the DCISionRT has been available, and it's on the market in the US and North America for some time. Just recently in Annals of Surgical Oncology, a registry, the clinical utility has been published. There's a large registry where clinicians are making treatment recommendations before and after getting a DCISionRT. And I hope you can see this, but what this shows is in 539 patients, the rate of RT use was around 70%, not very different for radiation oncologists or surgeons. And when you look here, the frequency of change in RT recommendation pre and post test was quite dramatic. Roughly 40% going from yes to no, and similarly, roughly 35 to 40% going from no to yes, with a total change in overall, but similar for both radiation oncologists, surgeons or tumour boards, of around 40%. So quite a dramatic impact. So in conclusion, this temporary Australian cohort from Royal Melbourne appears to validate the utility of the biosignature in determining the prognosis and predicting the radiation benefit in patients with fairly large areas of DCIS, not trivial disease. It does appear to address presently unmet needs on DCIS assessment, and there are advanced plans for a prospective decision impact and clinical registry are in place. Where is the future? My firm view is that what is needed is a randomized trial of management of DCIS based on the standard clinical pathological measures and the guidelines, with or without DCISionRT. I think the experience of Oncotype and others is that in Australia, where it's unlikely to get public funding without such information, and I think now is the time, or fairly soon will be the time for that. And it's happened again. I don't know why. Can you see? Yeah. And the other thing, there are aspects of the assay. It could be that the assay is able to identify patients for whom surgery may be omitted. Maybe those with a very low decision score are those who could be safely watched. Those with a very high decision score, there is a worrying increase in the in the graph with a high rate of recurrence, even with radiation, and maybe those are ones who need some systemic therapy or maybe a mastectomy. And even though it's uncommon, there are patients who have a distant relapse after DCIS, and maybe there's something in the assay. These are things that work is happening, and it will be interesting to see where it goes. So thank you for your attention, and I'm very happy to take any questions.
Thanks very much, Bruce. Really interesting talk, and the questions are coming in thick and fast. Just one comment on your slide very early on about radiotherapy, which is a paper published in 2017 looking at lung cancer-related mortality in breast cancer patients and describing it to modern radiotherapy. I mean, one issue I have with radiotherapy is that it has actually evolved quite a lot. And cardiac toxicity and second malignancy to some extent are late toxicities. The way we treated patients back in the early 2000s is quite different now to what we did then. They were probably treated in some cases without CT planning, proper cardiac dosimetry, and certainly without GIBH. I'm not critiquing it or negating it, that's the best data we have, but I'm just pointing out that we need to collect good data on radiotherapy toxicity going forward. Now, lots of questions, and the first from Stephen Fox, who has a host of questions. Stephen's saying, thank you, very interesting and important work, but first of all, he has a question about the methodology of the study. Was all the assay analysis done in a single lab? That's the first question. And then
yes.
there's a whole host of series.
Yep.
And do you have any information about the platforms that were used, the chromogenic methodology, how it was quantified, and where else is doing the assay now?
The assay is all done at the Prelude's Pathology lab. It's a CLIA approved lab in California. There are plans, they have some plans on how to distribute it and whether it can be done. I think there are plans that kits could be made available, so the pathology could be done in a distributed manner and then images uploaded into the cloud where the algorithm is run. As far as the specifics, I have to admit I'm not a pathologist, so I can't give specifics. I'm very happy to put Stephen in contact with those who can.
I think that might be interesting to do, because I guess he's pointing out that there are issues around assay variability for particular parts of the assay, and which can affect it. And there's probably also issues about transferring it to different laboratories, and you need some accreditation across laboratories.
Which I think is the reason that some prospective trials, I think a prospective registry with outcomes will be helpful, because that would be real world evidence of whether decisions made using the assay lead to the excellent outcomes that are suggested in these validation studies. And ultimately a randomized trial of using it versus not using it, that's the proof. And I think that is what's going to be needed.
Yeah, and I suspect he's also alluding to the fact that it would be helpful to have multiple laboratories with strong credentialing and cross-credentialing across the laboratories, because he's asking about concordance between different observers, different pathological observers, and about attrition rates in the validation series. And you may have some information about this. How do they select in or out patients who are included in the validation series, for example, at RMH? Because there is some heterogeneity.
No, that was all patients on whom we could get blocks with enough tissue, and it was there was no selection. It was absolutely every patient who we could get the blocks were included. One of the points, a great point that Stephen makes, that the Prelude people point out, is that grade is not included in the algorithm because grade is variable, whereas the markers they use with appropriate controls are more are more reproducible. Now, I haven't seen, or I'm not in a position to critique the strength of that statement, but that is the logic, that if you have something that is somewhat subjective, such as grade, that it would introduce a variability.
Yeah, and in fact, John Collins has asked what the concordance was between the grading at RMH versus, and if that was cross-assessed by the team at Prelude.
Yes, it's a good question, and we did do a central pathology review before sending it, and they reviewed again. But I think because grade isn't necessary in the algorithm, what they did is they confirmed that it was DCIS without invasion. I can ask, but I don't think they reassessed the grade. It would, you know, it would be interesting to see whether they agreed with us.
And so we might move on from that. And it sounds like Stephen's got a lot of questions, so probably worth contacting him one-on-one about those. But there is a question about adjuvant hormonal therapy, because obviously endocrine therapy is prescribed for patients with DCIS. And we're just wondering about the utility of this assay in an environment where it is being used.
Yeah, so I did present that. So when we did an analysis, those with and without endocrine therapy, and the trends were exactly the same, but the absolute difference in benefit from radiotherapy in those receiving endocrine therapy was smaller. It was 27% in those without, 20% in those with. But nevertheless, you know, both substantial benefit, and the reverse in those with a low decision score, whether or not endocrine therapy was recommended, there was no benefit from, no reduction in event rate with radiation.
Okay. All right. And then a couple of questions around the acceptability of emitting radiotherapy for patients, and about whether you think patients will accept those, will accept having lesser treatment, and is there any point in treating those, and what treatment should they be offered if we don't offer them radiotherapy, if they're considered low risk?
So my experience with, my experience with looking after women with radiation and experience in the Prospect study is that many patients are very fearful of radiation. They're prepared to have it if recommended, but if advised that it can be safely emitted, they're delighted. So I think the fear is more on the part of the provider rather than the patient. If someone's low risk, I think still wide excision is indicated. I don't think we're at the point of getting an assay on a core biopsy and doing nothing, although it would be nice. I think the evidence from IBIS and other studies that endocrine therapy, tamoxifen, can act as a chemopreventative. This work has no impact on that. So the algorithm would be DCIS identified wide excision if pure DCIS, and a patient has a DCISionRT that shows a low decision score. That would be reassurance that there is no benefit from radiation, so she can safely emit that. And then as a separate issue, consider endocrine therapy to reduce future events. And if it is well tolerated, she takes it, maybe at a low dose. If it's poorly tolerated, she could decide to cease it. That's how I would, see it going forward.
I mean, it is interesting, I think, because the toxicity of endocrine therapy for many women, particularly young women, is quite substantial. So I'm not saying that I don't disagree with your approach, but it's one of the things they complain about the most to me, actually. after the
and so that is my comment about, if well tolerated, continue, but if not, then cease. But I think this, if an assay like this is able to separate the two discussions. Endocrine therapy is clearly as a chemopreventative agent in someone who, because she's been diagnosed with DCIS, we know she is at higher risk.
Do you have a sense of what your patient cohort considers low risk? Kylie Gorange has asked, what percentage of recurrence risk is acceptable to women? I think that's a very individual decision.
Yeah, it is. I think it's a great question. And I think we as clinicians need to be skilled communicators around that. I think the low decision score group is actually easy because there's really no benefit from radiation. Those who have an elevated decision score that's maybe 3 to 4, where the difference, the expected reduction in event rate is about 4 or 5%, then I think it's an individual patient choice. Where it's higher, where the difference is, say, 8 to 10 to 15%, then for most women, that's easy. It is interesting, there seems to be a floor below which the event rate doesn't fall, even the low risk patients.
Mm-hmm. And I note that family history is obviously included in the algorithm, but it's often a very strong driver in patients' decision making as well. So is it theoretically possible for a patient with a strong family history to end up with a low risk if the other factors are...
Family history isn't part of the algorithm. The clinical factors are age, margin, palpability, and size.
Okay. All right.
I think family history relates to the risk of subsequent events rather than the natural history of the existing disease. I think that's the case. I don't know of any evidence. I guess a local recurrence in. I'm not sure that there is anything in the DCIS literature on the impact of family history on recurrence rate. We certainly didn't take it into account in our study. Okay,
and it's not included in the algorithm?
No, it's not.
Sorry, I misunderstood it because it is included in the multivariate analysis in one of the trials. But okay, and then just another comment from John Collins asking if it's time to repeat the SIME-COAT study on what recurrence rate in DCIS is acceptable. And I must apologize, I'm not familiar with this.
Oh, yeah. That's a bit of a Dorothy Dixer. I think it really is. I think that it's not only in this, but in many areas of cancer medicine, a more sophisticated assessment of risk benefit from a patient point of view is needed, because the idea that in an MDM we can decide what is right for all or most patients, I find that hard to believe. I think in lots of situations where the absolute benefit is small, the patient's desire, the patient's views are critical. And actually unpredictable. There are, I actually had a 74-year-old who had a DCISionRT that suggested a benefit from radiation of about 4%. This is what I referred to before. I didn't know what she wanted, but after quite some discussion, she came back and said, yes, she wants treatment. I thought she wouldn't, but she did, and so she's off having radiation, which I think is a good outcome.
Mm-hmm. I suspect we underrate the ability of patients to be informed about risk a little bit. And there are interesting studies emerging in that. I mean, one of the issues here is if we were to do a phase 3 trial, and I think that's admirable, but reality is it's going to take years and years and years to give us information for this and be quite challenging in many ways. And you would understand that from your involvement with BCT. is that result going to make a difference to patients if it's essentially, it's a sort of complicated discussion about risk, which we are not that great at engaging in ourselves. So do we also need to do studies looking at how we handle and discuss risk?
Okay, I'd say those things are complementary, but the situation, if we had a patient and the advice to her was we can make our recommendation using our standard test that we have done for the last 20 years, or we can, but there is a new assay that we're not quite sure of its role, but we could potentially use that. Are you happy to be in a randomized trial where we either use the test or don't use the test? I think most people would say use the test. The outcomes, the early outcome would be patterns of use and rate of change. That would come early. It's true that it would be 5 years before one had any meaningful results and 10 years until we had definite results. But it is remarkable how quickly 10 years goes past. And I think the experience of Oncotype, we've had the studies like these ones since 2004, 17 years later, and it's still not funded. So I actually think it's urgent that we do, if that's what will be necessary to demonstrate the value or disprove the value and allow this to be funded.
So it sounds like there are a few steps. Another comment from Stephen saying that multiple of the markers, Ki67, COX2 and SIH2, have significant heterogeneity in their interpretation and assay outcomes. So I think that he has some questions about the robustness of the assay.
I did introduce, Stephen met Troy and discussed this when he visited Melbourne a few years ago, and I'm sure would be happy to continue the discussions. That sounds like it would be. A lot of ongoing work with a number of Peter Mac investigators. They are working with Prelude to continue to develop the assay. With all of these, it's unlikely that the original assay is the absolute best, but to me, the results are quite impressive.
And just another question, a practical question from Chen Liu, one of my colleagues, whether DCISionRT is routinely being used in clinical practice, or is it only available as part of clinical trials, both in Australia and internationally?
So in Australia, it's rarely used. Up until now, it's a few people who've known about it. I'm not sure. I've done the work, so I've been able to get access. There are plans. What's actually the background to it is that Genesis Care, one of the radiation providers, owns 21st Century Oncology, which is a major oncology provider in the US. Frank Vicini, who is one of the prominent radoncs, works for 21st Century Oncology and with Prelude, and therefore the two companies are working together to make it available. I think they have insurance coverage in the US, so they are pushing hard for it to be used. I don't think it's used very often. In Australia, there are plans fairly well advanced to launch a registry study here as well, and that will be announced in due course.
I think we've only got 2 minutes to go, and I don't see any new questions, but it's fantastic discussion. Thank you so much for answering so generously. This has been recorded, and it will be available for you all to look at. And I'm sure also Bruce would be very, very happy to answer any questions that we didn't get to during the course of the discussion. And I think we're pretty much done for now. So thank you very much, Bruce. It's been a real pleasure and very interesting. Yeah.
Great. Thank you very much. Good.
Thank you.